All right. So in the primary care setting, about a third of the injuries we see are preventable, and as I mentioned, in long-term care, a little more opportunity for it. So definitely some work. I love Betty White. I miss Betty White. She was a pretty incredible person, and I like that glass of wine. That looks like the perfect size pina colada for poolside. But one of the things, so she lived a very long life, a very healthy life, and one of the things she sort of preached all around the country is moderation. You know, she talked about movement and the importance for older adults to continue to move and exercise their joints, to enjoy the things that you have in life, but not in excess. And so she lived sort of a good life of moderation. And she always talked about how she scheduled her life to make sure that exercise and healthful activities were a part of her daily routine, and also that she felt like she had to be very self-advocate when she was getting medical care, to make sure that she understood the pros and cons of treatments, and that she was really challenging her prescribers if there were non-drug approaches. So she was really sort of an active patient and an active person in life. So I think she's sort of a good prototype, or was a good prototype, for how we can encourage older adults to navigate the healthcare system, because we're in a very transactional healthcare system, regrettably, in the U.S. If you have a complaint, you can probably get a drug for it, and that's not always the right thing to do, particularly in older adults. One of the things that happens, and I see it all the time in our polypharmacy programs, is a medication was started for an older adult. The issue is not really necessary to be treated with drugs anymore, but that drug follows them for years to come. And so sometimes it's nice to put like a stop date on a medication and say, we're going to reevaluate this and see whether or not it's absolutely necessary. I've seen that with bisphosphonates leading to a lot of injuries. I've seen that with proton pump inhibitors being started not for a short period of time, but being used for years, and that leading to issues, all kind of issues now with bone disease. And so it's sometimes about, is it the right drug? Is it the right duration? Can we use non-drug approaches? So keep challenging the situation. So physiologic changes will happen in the body as we age that make medications work differently, and then certainly disease can sit on top of that. And then older adults may have activities that change the way their body handles medications. But what are some of the physiologic changes that you think about in the older patient that we're aging that could have implications for how drugs perform or how safe they might be? And some of them are good, and some of them are relatively depressing. What are some of those physiologic changes you observe in your older patients? Renal function, so kidney filtration and blood flow changes, and in fact, in the older patient, we typically see one of three scenarios. A third of them have age normal filtration kidney function. A third of them have sort of mild to moderate disease, and then a third will have severe disease. So 2/3 of the groups that we see may need some adjustment of their drug therapies because of kidney function. So that's a great one. And the number one that I see in our clinics. Number one thing I see is someone who's been given a medication that's not dosed appropriately for their kidney function. What else? Isn't it super depressing? Regardless of what we do, we lose body mass and we put fat in the place of it. It's very upsetting as an aging man. I deal with it every day, for sure. What does that have to do with drugs? Yeah, right? So think about it. If anybody's been a part of running clinical trials, I've sort of done it all my career. It's young, healthy people that are in trials. So these medications we study are in college students that'll do just about anything for $100 a week to be in a study. And you now take an older adult, and in the simplest form, it's like the young adult here is a full glass of water, and the older adult that the drug is actually intended for is not as full glass of water. You drop 10 milligrams of drug XYZ into it, and what happens in the older patient, in the less full glass of water? It's more concentrated. So that puts more pressure on the system to eliminate it. It potentially makes the effects exaggerated. If the drug really loves fat, it may sort of hang out in the body longer and accumulate and come back into the bloodstream at a not opportune time. And so it really does change the way not only that the drug moves in the body, but it can change the way we have to use it, because the clinical trial might not have represented that population very well. That's why geriatricians always say start low and go slow, because every time you use a drug in an older adult, you can think about it as sort of a individual clinical trial. You may not have any real world evidence to suggest how that drug works. And there's some drugs, like Dr. Beers from North Carolina, before he passed away, helped create the Beers criteria. And he and his team have helped us sort of identify some medications that are just really unpredictable to use in older adults. And he has always suggested to try to look at other safer alternatives. What else? Anything else? Few things. So fat increases, we mentioned. As fat replaces muscle, muscle means water, and so we lose both total body water. You don't see quite as much like cytokine enzyme activity in the liver is decreasing with age. They tend to be fairly well preserved. But the main thing you see in the liver is you just have less blood flow. So as circulatory changes as we age, less blood flow means less drug being exposed to extraction and the effects of liver metabolism. And so you can have more drug present because less of it is being eliminated in the older patient. And then you may see nutrition related. I rarely see issues in older adults unless they're cachectic and very, very anemic with sort of plasma protein issues. It's not something that I have seen over the last 20 years much in the clinic. So while plasma proteins may be decreased, unless they're very ill, it's usually not a clinically relevant problem. The one thing we do see though is for drugs that are highly protein bound, if they're on multiple drugs, you may see interactions. But I rarely see someone who's so proteinemic that they have issues with higher levels of free drug in the blood. So a few things there. I think still to this day that managing medications in an older adult who has heart failure is probably the single hardest thing to do. I mean, in the renal failure side, we have dialysis, which is kind of like resolves the issue for us. And nephrologists are notoriously good at helping to regulate those drugs. But for the heart failure patient, the third spacing and the change in cardiodynamics, it makes it very, very difficult to manage medication. So that's a tricky one. I also find it tricky to manage some medications in folks that have had gastric bypass surgery. And I've found over the years that extended release and sustained release products can be really hard in that population, particularly if there's been a change in their actual pathway for drug absorption. But those are a few. Anybody do sort of polymorphic or genetic testing to check about weird issues with metabolism or drug safety? I don't really do much of it either. It's out there. There are, in some of the more concierge programs and some of the specialty clinics and academic medical centers, you see a fair amount of testing. There's some companies out there that do it, but they haven't really published results about the efficacy. So I don't think we're quite there yet. We'll probably get there as personalized medicine takes a little more hold. But right now there's not a lot of practical applications or affordable applications of personalized medicine in terms of metabolic testing. I do sometimes for individuals of sort of Asian or Asian Pacific heritage. There's a number of drugs in the cardiovascular family that can create some issues. I do a little bit more testing there if I'm going to be using drugs like statins. If I see individuals of Middle Eastern background and I'm treating them for some GI or hematologic issues, I may do a little testing. That's pretty much about it. Not quite there yet. So let's look at a patient. She's a really lovely one. But Anne, let's see what our questions are. Oh no, that's just chatting that they can hear us. Perfect. So Anne came into a primary care clinic. I was part of the team there. One of my colleagues took care of her, but we sort of looked at her case together and I sort of wrote it up. But she came into a primary care clinic. It was on a afternoon, and this practice, it's community-based practice. It has a family medicine residency embedded in it. So you got pharmacists there. It's one of the sites where we had a polypharmacy program. And Anne came in with her daughter. So she had fallen the night before. She was getting out of bed in the middle of the night to go to the bathroom. And she came in and she was ambulating, fine. She was complaining about a little discomfort in her left hip, but didn't seem affected in any way in terms of her gait or ambulation. But it was uncomfortable where she fell on it. During the course of the interview, she starts to sort of open up a bit about the loss of her husband, and she gets tearful and is really still experiencing now past the period of a grief reaction, but sort of some longer lasting, now close to a year of disruptive symptoms related to grief and probably depression, but it's having a hard time there as well. This is her past medical history. Let y'all take a look. You remember what we said earlier about the statistics? She's older than 75 and she's got more than 4 chronic illnesses. So she's in the high risk group for drug injury. Just reminding you of that. What do you think about a person diagnosed with dementia 18 months ago at age 86? That one made me scratch my head a little bit because she comes in regularly for assessments. And unless she's had a fall or something else, it's really unusual to see like an Alzheimer's dementia present that late. So we can scratch her head about that a little bit. Okay, keep rolling on. She had a C-section at age 23. She only other sort of surgical history, which was minor, is she had a chest wall basal cell carcinoma taken off. But other than that, she's had no other surgeries. Adopted, so we don't know about her family history, but she's been very attentive to her health over her adult life, her adulthood. And to kind of give you a little bit more about her story, so her husband passed away. She started having some difficulty maintaining the home and also a little bit of financial difficulty. It was, it was tough. So her daughter moved in with her. Her daughter worked, during the daytime. So she would, they would be together at night and in the morning they'd have breakfast together. But her daughter would also pull her medications together. She had some respite care that came in, like a church-based respite program that came in a few days a week. And that was good. And she had a couple social activities each week that she did with friends. And it was a good dynamic. And if you work with older adults, you work in geriatrics, you see all versions of mother-daughter or father-daughter, father-son relationships, good, bad. This was one of the very best. They were supportive. Her daughter really respected her mom's autonomy. They were good friends. It was a really nice, loving, supportive relationship without the I'm the child but the parent now dynamic, which is my least favorite of the of the presentations. But this was a beautiful relationship. They helped one another. They owned the home, so they really just had to cover utilities and taxes, which made it easier for them. And it worked out pretty well. So that's their kind of story. Here's her drug list when she came into the primary care clinic. I'll let y'all take a little look at that, and then I'm going to ask you some things about it. Y'all know all those? I don't think there are any too off-the-wall ones. Let's just sort of go through it, just based on what you know about her. I hadn't given any physical exam, hadn't given any lab tests yet, but just based on her medical history, her history of her present illness, and what I've told you about her from sort of a social and family history point of view. Any concerns about the acetaminophen? What you thinking about that one? Pretty safe. So what would be the daily maximum? Of course, not knowing anything about her liver health, but assuming things are okay, what would you say is a daily maximum for her if she's treating any kind of chronic pain? Yeah, so I think for a normal adult, 4,000 milligrams a day in a short-term use would be really a max. For a chronic use, we'd really want to keep it at 3,000. So that would be more if she's actually using it. We could find out how often she's using it. If she's using it for sort of arthritis pain, we could also lower it to the arthritis strength dose. So she's getting 650 each dose rather than 1,000. So depending on how often she's using it, she may not be using it much at all, but I think that would be worth asking. How about the Boniva or ibandronate? Good question. Let's hold on to that. If I tell you 20 years, we're going to be concerned, right? If I say 3, maybe less so. All right, so good one. How about cetirizine or Zyrtec? So what are our concerns about antihistamines in older adults like her? Yeah, so if you think about the effects antihistamines would have, they can be sedating, they can cause blurry vision, they can cause orthostasis. This is not one of the non-sedating ones, so this would have sedating properties. The other thing, what else is going on in her medical history that would make you concerned about cetirizine? So it is listed as a daily medication. What about her medical history would give you some pause here? Yeah. So let's think about it. She's being treated for dementia. I'm not sure that's the right diagnosis, but we'll find out And so the dementia treatments are trying to preserve acetylcholine in the brain as much as possible, right, to help keep cognitive processes going. And then we're challenging that with an antihistamine. So there's a drug disease interaction with that one as well. She's also had a fall, and histamines can be, anything that kind of works from the neck up in an older adult can increase fall risk. So I think definitely some suspicion around that one. So let's hang on to that. Donepezil, we'll talk about the ginkgo biloba was something that a friend of hers in church recommended she start taking. She's on a metoprolol, low pressor or beta blocker. Any concerns about that one? That's probably a pretty good choice, right? Atrial fibrillation, hypertension. The beta blocker can have really some good effects on preventing cardiac issues, stroke. Might be good with rate control. How about the oxycodone? Would it make you more comfortable? I tell you she was crushing it and snorting it. No, I'm kidding. Yeah, exactly. Yeah, I mean, I guess for me, when I saw her, my sort of, well, when we were looking through the case together with a colleague, I was sort of like, why oxycodone? I don't really see anything history that suggests that that much of an issue with pain. So I was kind of, and then I was also thinking about she's had a fall. Here's another drug that works from the neck up. So that could be an issue. And then warfarin, she's on for her AFib. Any thoughts about that? The fall definitely be a concern. Fortunately, she didn't bump her head, but yeah, I think for here we could look and see like what's the potential benefit. Is she indicated for the anticoagulation? She does have AFib, so I mean, there's hard to beat anticoagulation. We could also look at like a hemorrhage score or a bleeding risk score, and sort of look at the pros and cons of anticoagulant versus antiplatelet therapy. Uh, I don't know. So the comment for our folks on Zoom is about an interaction between ginkgo and warfarin. And I have thought about this. Maybe my other pharmacist friends can help me, but I don't know of a single herbal supplement that starts with the letter G that doesn't interact with warfarin. Ginseng, ginkgo, gugolipid. I mean, you kind of go down the list. They all do. So that can be an issue. Okay, some good stuff. Here's a little bit more about her review of symptoms. So she's having some bladder incontinence. She's having pretty much nasally focused, a little bit of eye symptoms, but primarily nasal rhinitis seasonally. This hip pain that she describes, recently, the mild hip pain, but her osteoarthritis symptoms really amount to stiffness in her knees when she wakes up. If she takes a shower, if she moves around within about 15, not more than 20 minutes, she's okay. So it sounds pretty classical in terms of osteoarthritis. And then denying all these. So let me give you a little physical exam. I had to try to squeeze it all into the slide, so I'll let you take a look. Anything jumps out, let me know. Anything relevant or raising red flags? Am I blocking you guys, or can y'all see okay? You can see okay? Okay. So the orthostatic blood pressure issue could be a part of why she had her fall. She could have just tripped as well, getting up in the middle of the night. But I think looking to see whether or not there's some orthostasis and was a smart move on the clinician. She's still in AFib, but the rate looks reasonably well controlled. Okay, just a little bit more. With her, she has some urogenital findings, and she's also having complaints of incontinence. So if she hasn't seen urology or urogynecology, that would definitely have been a good idea to see if there were some interventions to support her. She's not going to be a candidate for the gotta go right now kind of medications because of the dementia. So we'd want to be looking at some other issues. Would you x-ray her hip? Who would? Some? Would you some just watch it? Yeah, I think when I talk to groups, and I've used this case about half and half, I probably would have x-rayed it myself. Not that expensive, and I think if we had identified something, it'd be more helpful than not. Here's the neuropsychiatric information from the chart. So she definitely has a significant finding on her mental status exam, and there's some CT findings as well. I was still not convinced she had. I was wondering what type of dementia she actually had. She was referred to neurology after her visit here. Definitely, fairly independent though. Here's some labs. Let me let you take a look. Not so worried about the acetaminophen and at least not indications of liver issues. And if you look at ratios between that one and the outfloss, it looks like she's probably okay there. This was not a fasting test. INR is a little bit on the high end. So with her native vowel, we'd really want to have her between 2 and 3, right? So she's a little bit on the high side. We could pull her back a little bit. I can't stand a complicated warfarin regimen. It's one of my peeves when you like take one on Monday and a half on Tuesday and you lick it on Wednesday and throw it over your shoulder. I think it's very confusing for patients. And I can't tell you how many home visits I've done where people have 5 bottles of different colored warfarin and they all say take as directed on the label and they're very confused. So I understand that sometimes you have to do that when you get somebody to target INR. But what I typically try to do is once we get them stable, take the weekly dose, divide it by 7, try to give it, 6 p.m. every day, just keep a fixed dose. I think it's much easier for older adults. What do you do about that? I'm not going to talk about that because that could be our whole conference. But there's a lot of controversy still around vitamin D, around cancer, around heart disease, and we've correlated low vitamin D with a lot of disease processes, but very few have shown benefit in terms of actual treatment. But for her, with this low vitamin D and an osteoporosis diagnosis, I think you're in good stead, supported by the evidence to treat that vitamin D deficiency, along with calcium, and she needs it in sunshine and exercise. Okay, so CT scan did show some generalized cerebral atrophy. Her T-score, we're going to talk about osteoporosis, but she's in it, right? She's more than 2.5 standard deviations below, so she's osteoporotic. And as we mentioned, she's on a rate control AFib. So what risk factors for fall did you recognize in her history? And let's think about those that we could do something about versus it's just part of her makeup. What are some of those risk factors? You tell me. So anything, those drugs we talked about, working from the neck up, the cetirizine, the oxycodone, all of those can increase fall risk. Any central nervous system active drug. 3 or more is actually a high-level risk factor for a fall in an older adult. She's on 2. And maybe she's having some of that Betty White Pinot Noir, so that might be a 3rd. We'll see. Yeah, I mean, if you look at her age, her gender, regrettably, we can't, those are risk factors. Nothing we can do about that. Low BMI is another risk factor. So skinny, older female is there. But her orthostasis is a complaint, is an issue. Her cognitive impairment is a known risk factor for fall. She's on medications that work above the neck. And then if she is in fact depressed, depression is also a risk factor for falls. And treating depression can actually has been shown to reduce the risk of fall. And any activity that causes abrupt awakenings or middle of the night awakenings like urinary incontinence will also increase fall risk. So I wonder if she's been if sort of working that up and dealing with that could definitely lower her long-term sort of fall risk. I don't know if she's like my mom, but like when I go home to see my mother and father, my mom has now inherited every piece of furniture from every relative. She has hundreds of rugs in the house. I mean, it is like an obstacle course to get from one end of the house to the other. And, there's no supports in the bathtubs. Everything is like it was when I was a kid. Not a great environment to age in. She fortunately has her bedroom on the first floor, so that's a good thing. But I don't, you could also look at her home. Does she have trip hazards and things like that? I love home health assessments for people's home conditions because they can help us quite a lot, make the home safer for folks. That might be something we could do. So we talked a little bit about these, but anything since I've given you more laboratory findings that you'd want to put on your list to address? Or I guess my question for you is, what would you do next? So I'm putting her in your hands. She's there complaining about this hip pain and this urinary incontinence, and you have her history, you have some recent laboratory data, you have her physical exam. What do you do? So let's think about the metoprolol because her orthostasis was present. Her rate was looking okay. So what would be our option? So one option would be you said lower the dose of the metoprolol. What else could we do to metoprolol? You could split it. What if, I mean, one thing that would be really helpful is to have her take some blood pressure readings in the morning, during the day, at night. Remember these strokes are generally going to happen in early morning hours, late night, early morning. But I think it would be good to see what her blood pressure and heart rate are looking throughout the day. But one alternative would be you could give her 25 in the morning and 25 at night or something like that. But I agree with you. We need to do something to regulate the blood pressure without causing the orthostasis. What else? Thanks for being the brave one to jump out in front. What else? What do you want to do about that? You want to let it go? Be bold. Be like Maya Angelou. Be bold. Cut that thing off. Bye. You know what I love about antihistamines and treating allergic rhinitis in older adults? All right, this is a general rule I'll share with you. If you can squirt it, spray it, smear it, slab it, do that rather than swallow it. That's the way to do it. So nasal spray, a corticosteroid nasal spray would be a lovely idea for her. And the nice thing about that is intranasal corticosteroid not only improves nasal rhinitis, but it's shown to help allergic conjunctivitis. She might even get benefits in her eyes. But you could add an eye drop if you needed to. So I like the idea of a local solution without getting that into the bloodstream. What else? So she has been on the Beniva, the ibandronate for 10 years when they saw her in the clinic. This was her 10th year. What you want to do? Do you want to do anything else? You just want to let it go? So the issue with the bisphosphonate, absolutely a gold standard, right? For osteoporosis in a postmenopausal woman like her. It's a good choice. It's a monthly treatment. That's nice. But really, the data that we have on the bisphosphonates, which we'll dive into more, really at 10 years, the benefit has sort of been exhausted. The harm is a bit up. And we'll talk about kind of how long you go, but somewhere between 7 and 10 years is definitely kind of the end zone. So at this point, she's had a recent BMD that still shows osteoporosis. We could change her to another medication. You could potentially give her a drug holiday, but we might want to think about continuing a different treatment. But I agree that for the ibandronate, it's been long enough. And so you want to regulate the warfarin a little bit to get her to a better INR. I like it. Would anybody change her to an antiplatelet or something else, or maybe do a CHAD2 score, some bleeding or hemorrhages score, maybe do some assessments? Yeah, see it maybe if one of the direct thrombin sort of drugs could be better. I think it's worth a conversation. It's difficult when someone's had a tumble or a minor fall, an older adult. The risk of a stroke or heart attack for her is quite high at her age and with AFib, and so I think you'd have to kind of weigh that back and forth. But it definitely would give a little thought. You definitely simplify it as you're coming down to try to get up, maybe put her a little more at the 2.5 range. Okay. So I think, the oxycodone, maybe you start with that. Are you using it? How often? Why are you using it? And try to figure out, what's the point? What we actually learned about her with the oxycodone is it was given to her from primary care physician a while back, and she was using it at nighttime for arthritis pain, but it would also kind of use it at that time to help her sleep a little bit. I really don't think that would be a great choice. And so I probably would have pulled that one off. And again, you could use a topical treatment if she's having, local issues. Voltaren gel works okay for the knees. You could do some lidocaine, and maybe even just acetaminophen and see how that goes. you could lower that dose of acetaminophen, right? Maybe max her out at 3,000 a day. I think, so the question here is, do we add a tramadol, an opioid? I think the thing to do is assess her pain level, her functional level. And what I heard from her, from my colleague as we look, is that her knees were achy in the morning and stiff, but if she worked them out and exercised them, she got around okay with the day. And occasionally, if she was walking a lot, they would be sort of achy. I don't think she needs anything other than the acetaminophen, exercise, and some topical therapies. Because the idea of using a tramadol rather than the opioid would sort of be sparing. But again, it's another drug that works from the neck up. So, but I'm kind of with you. I would really try to exhaust topical therapies. And I mean, it's hard to underestimate the importance of regular exercise for arthritis pain in older adults as well. I'll even put those like copper wraps on the knees, anything to try to see what people will respond to. But exercise is definitely sort of the lubricant for our joints. And so keeping her moving would be really important. Be good for a lot of things. So, I mean, y'all really hit a lot of sort of what I would share is too. So the falls we mentioned, she's on 3 drugs that work the neck up. I agree, let the cetirizine go. Maybe you could even incorporate physical therapy to make sure she knows exactly the type of exercises. She could also do sort of water-based exercises with older friends. For the osteoporosis, we mentioned supplementing the vitamin D, and we also mentioned this issue of the bisphosphonate duration. And one suggestion was, if you want to put her on another drug, maybe consider Prolia or denosumab, another kind of drug other than a bisphosphonate for the next go round. I think that would be reasonable. I'd definitely get rid of the ginkgo or anything with the letter G. You could look at the Beers criteria, but I think we made the agreement that we don't want to use an antihistamine in an individual with a dementia diagnosis. I'd do a home health assessment of her conditions. I would try to encourage an exercise program or physical therapy if she would go with it. I would probably x-ray that hip just to make sure. Like you mentioned, I would sort of do a critical assessment of her bleeding risk versus her likelihood for macrovascular disease using like a CHAD2 score. And I would sort of reassess that anticoagulant. I think those are the things I would go for. Refer to a urogynecology, see if there's things that we could do to support the incontinence. And sometimes I find that antihistamines sort of complicate the incontinence. So it may be that gets a little bit better when we stop the cetirizine. So, one of the things I wanted to sort of share with you about her is when you're looking at someone and you're dealing with the complaint, but also the polypharmacy issue comes in, you can deal with it in kind of the way that we did, this organic way where we just sort of go through the medications and think them through. That works if the regimen is not too big and long. You may find that style works best, but I found over the time, as the list of people that I was being asked to see was, went from 8 or 10 drugs to 14 to 20 to 30 to 40. I just couldn't do that. And I had to have sort of tools that made it more efficient and made sure I wasn't missing things. And so as we get into round 2 in just a minute, I will share with you some of those tools. You can still apply it in a situation like Anne, but in a patient that has a more complex drug regimen, it really helps me do things much more quickly, and it helps me not miss things. So you can sort of see what you like, and you can pick up what you want to use, and you can ignore what doesn't feel good to you. And then hopefully you'll be a pro polypharmacy assessments. So a couple other things that we mentioned. One thing you could do for her if you wanted to stay away from drugs, you could use hip protectors. She's pretty much staying at home, and hip protectors they're less than $20. You can place them, like her daughter could if she's helping her dress, she could place the hip protectors on. And the trials, comparative efficacy trials, show they're just as good as like drug therapy to prevent a hip fracture if in fact you fall. It supports the hip. So that's a non-drug option you could think about as a hip fracture preventer for sure. Okay. We went through all those.